Well, one, I want to welcome you all here to Catch Your Breath with PSV. We are so excited that you all decided to join us. My name is Corisha. I am the physician liaison here at Pediatric Specialists of Virginia, and it has been great building this relationship with you all. Today, we have our pulmonologist, Dr. Corey Martin. He will be discussing the topic of asthma, and I am very excited for us to get this opportunity to share this information with you. You are welcome to ask questions. We do ask that you wait until the end so he can answer all questions, at the same time, just so we can review the information first. So without further ado, I'd like to introduce you to Dr. Corey Martin.
Hey, everyone. Glad to be here. I'm really excited to have this talk because I think it's going to elicit some very interesting discussion at the end. I'm glad I get to talk after our last meeting, which actually didn't turn out too well. But glad that everyone's here and we can get this lecture started. So the title of my presentation is The End of Albuterol or Not. And we're going to talk a little bit about what's happening with albuterol, why we may be kind of shifting away from using it, as surprising as it is, or in kind of the obstacles that still remain in the way. So the objectives today is to talk about the major changes of asthma management that were initially brought out by the 2019 Global Initiative of Asthma Guidelines, and also talk about the update in 2020 from our own National Asthma Education and Prevention Program. I have no conflicts of interest. So I want to take you guys back to 2019. What a year it was. There was no COVID. At least we didn't know that COVID existed at the time. Avengers, finally coming to an end with one of the greatest movies ever made. Cruise ships, still a thing. We were on boats, crowded together with no problems. And then the Global Initiative for Asthma came out with probably one of the biggest updates to asthma in decades. And so what is GINA? So GINA is a Global Initiative of Asthma. This is basically the European international group that does collaborate with our own National Heart, Lung, and Blood Institute and the World Health Organization. And basically, they are responsible for coming up with guidelines for asthma, and they do it on a yearly basis. So it's really great to kind of just follow them every year and see what's kind of new with asthma, what isn't. However, their guidelines are more focused on what's happening in Europe and abroad, and not exactly what we in the US are comfortable doing. And so this was a big thing in 2019 that kind of shook the whole pulmonary community, was this guideline for adolescents and adults with asthma. And I kind of highlighted and read what the big deal was about. So in step one, which is kind of the mild intermittent group, the preferred medication for this was as needed low dose ICS formoterol. All right, so this was huge. I mean, I think that no one has ever thought of using anything besides albuterol for as needed symptoms, but here we are, GINA coming out with. Now, albuterol is actually an alternative medication to use for symptom relief for older patients with asthma. We rather use Symbicort or Dulera. And then next step, in step two, was another big change where they recommended that with the use of a daily inhaled steroid, you can use albuterol with it, or you can just use, again, as needed low dose ICS formoterol. So this was kind of a big shock just because, again, we never thought there'd be a world in asthma management where we wouldn't use albuterol for symptom relief. And here in the GINA guidelines, they're actually suggesting just that. The other thing we want to kind of highlight here is that besides as needed low dose formoterol, they also recommend as an alternative to use a low dose inhaled steroid whenever albuterol or a short acting beta agonist was taken. In Europe and abroad, they do have inhaled steroids and a short acting beta agonist all together in one inhaler. In the US, we do not have that yet. So what this would look like is that every time the patient felt like they were having symptoms, they would take this one inhaler that was kind of like a Dulera or a Symbicort, but with a short-acting albuterol instead of a long-acting albuterol. So we see in those combination inhalers, and they would take that as needed. And again, these both management were preferred over just your regular short-acting albuterol as needed for symptoms. And the reason why they were suggesting the use of inhaled steroids and formoterol combined inhalers for even mild intermittent mild persistent asthma was based on these large randomized controlled trials that were comparing daily inhaled steroids, in this case daily budesonide, or a short-acting beta agonist, such as in their studies they were using terbutaline, versus as needed budesonide formoterol. And in these studies, they found quite a significant reduction in severe exacerbations compared to at least using as needed albuterol. And by severe exacerbations, we're talking about emergency room visits, unplanned healthcare visits, hospitalizations, or need for systemic steroids. And then when you compare the use of as needed ICS formoterol versus a daily inhaled steroid with as needed short-acting beta agonists, there is no significant difference in the frequency of severe exacerbations. However, the dose of inhaled steroid was significantly reduced in those patients who just use ICS formoterol as needed. Otherwise, symptom scores and adverse events weren't different compared to daily budesonide when it comes to symptoms, or daily budesonide or terbutaline, which is the substitute for albuterol in these studies when it came to adverse events. So then a year later, everything happened, right? So World Health Organization declared the COVID-19 outbreak, the world changed, we all were locked down. And then also the National Asthma Education Prevention Program, which is kind of the GINA form of asthma guidelines in the US, released their updated guidelines. So it's kind of no shock to see why no one really heard about these guidelines coming out. But before we talk about the new guidelines, I want to kind of go back to the old guidelines. So in the old guidelines, in 0 to 4 years old, again, step one, albuterol is needed. Then you go to a low dose inhaled steroid for these mild persistent asthmatics, and then you kind of just increase the inhaled steroids, or you can consider adding a combination inhalers from montelukast. Kind of the same thing for 5 to 11 years old, except that in this case, the long-acting beta agonists weren't really preferred until step 3 or step 4. And same thing with the 12 years and up. So here were the major differences highlighted in the new guidelines. And this is why I think it's really important to talk about, especially with primary care physicians like yourself, because a lot of these changes affect patients that you may be taking care of. In step 1, they recommended as needed albuterol, but in children ages 0 to 4 years old with viral-induced wheezing only and infrequent exacerbations, you could consider adding a short course of a daily inhaled steroid. So like basically daily inhaled steroids as needed. And we'll talk about further what that looks like. And then the only other change that in step 3, instead of going from a daily low dose inhaled steroid to a medium dose inhaled steroid, now it's recommended just to kind of make that jump to a inhaled steroid long-acting beta agonist combination inhaler with as needed albuterol. In the next table, we have the management for 5 to 11 years old. The two highlighted changes here are kind of pretty significant changes. This is so for these patients with mild to moderate persistent asthma, what they recommended was to use the same inhaler for both daily control and for as needed symptoms. So this would look like a ICS formoterol. So this would again be your Dulera and your Symbicort, and you use it as a controller medication but also when the patient was having acute symptoms of coughing, wheezing, trouble breathing, they would use their exact same inhaler to relieve those symptoms. And then finally, in your older patient, 12 years and up, one thing that I thought was interesting was, again, this kind of idea of using an inhaled steroid and albuterol together just as needed instead of using a daily inhaled steroid. And then in steps 3 to 4, it's kind of the same thing as your younger kids about using the same combination inhalers as both as a control and rescue. The only other things kind of that were added was the addition of long-acting muscarinic antagonists. It would be like your Spiriva to as an alternative medication for control. And also in step 5, kind of using everything as both the combined inhaled steroid long-acting agonist and a long-acting muscarinic antagonist, agonist with albuterol. So I want to talk more about this kind of the inhaled steroid sick plan that we saw in the first table. So again, these are for patients who are 4 years and under, who have viral-induced wheezing, and it's pretty infrequent. So we're talking about maybe a few episodes a year. In these kids, the NAEPP recommend a 7 to 10 day course of a high dose inhaled steroid. And by high dose, we're talking about budesonide 1 milligram twice a day, or fluticasone 220 micrograms, 3 puffs twice a day. And this will be started at the beginning of a cold. And the reason why we're suggesting this is that in 3 randomized controlled trials comparing this use of a sick plan to just using albuterol alone, there was a significant improvement in symptoms during these illnesses, and there was a 33% relative risk reduction of the need for oral corticosteroids for viral-induced wheezing. So the number to treat was about 5 kids. Of course, when we think about inhaled steroids, we always worry about long-term side effects, especially growth. In these studies, the effect of growth was conflicting. At least in the budesonide group, there wasn't any effect on growth that they've seen on long-term study. But in the fluticasone group, there actually was a significant decrease in height or in growth velocity when using a higher dose fluticasone. Now, we have these patients who wheeze every month, maybe with colds, but only with colds, and they kind of wheeze for like a week or so. And then you have these kids that maybe have viral-induced wheezing 2 or 3 times a year. I would reserve this plan for patients who are only having wheezing maybe every 2 or 3 months, just because when you're using the sick plan over and over again, the cumulative dose of inhaled steroid that these kids are receiving would be higher than just using a low-dose inhaled steroid every day. So if you have these kids that only wheeze with viruses, but they're doing it pretty frequently, if they're such as daycare, they're just getting sick every month or so, at that point, I would just recommend doing a low-dose inhaled steroid versus doing this high-dose intermittent steroids just as needed for illnesses. The other thing that was, again, kind of brought up in the new guidelines was this idea of using a low-dose inhaled steroid with just albuterol for mild persistent asthmatics that are 12 years old and greater. And so what this would look like would be the use of 2 to 4 puffs of albuterol with QVAR 80, 1 to 3 puffs every 4 hours as needed. The reason why they were suggesting this is because in 3 randomized controlled trials, there was no difference in really outcomes of these patients when it comes to asthma control or exacerbations. However, you could theoretically reduce the cumulative dose of inhaled steroids these kids are receiving. The concerns about this plan is the idea of trusting these older patients, especially these teenagers, with identifying that they need this and using it correctly. So we have these patients who are very poor perceivers of their symptoms. Basically, they could have significant lower airway obstruction and not realize it until they're basically in a full-blown asthma exacerbation. And then you have patients who actually over-perceive their symptoms. So even with just a very mild cough, they're reaching for the inhaler and using it. And so with both of these groups, you kind of worry if they're going to underdose or overdose themselves in this plan. The other concern is that even with low-dose inhaled steroids, it's not like that daily low dose is actually really doing anything long-term when it comes to side effects. So even if we're reducing their cumulative inhaled steroid dose, it's not like we're really reducing any adverse risk events in the future. The other problem with this plan is, of course, at least in the United States, we don't have an inhaler that has both a low-dose inhaled steroid and an albuterol. So now we have these kids carrying two inhalers instead of just carrying their one inhaler at school, which would be albuterol, and they're just taking their inhaled steroid at home. The possible benefits is that costs for these patients may be less because they're not getting an inhaled steroid every day. So the refills that they possibly need for their inhaled steroids will be less. And some patients may prefer as-needed therapy versus needing a daily therapy. All right, now we'll kind of talk more about the biggest change. And again, this is the use of ICS formoterol as a rescue inhaler. So at least in the GINA guidelines, they recommend using this even without a daily long-acting beta agonist inhaled steroid combination. But in the NAEPP guidelines, this combination needed for rescue is only used in conjunction with using it as a daily controller medication as well. And the reason why it's specifically aimed at Dulera and formoterol is just because the formoterol has a rapid onset of action similar to albuterol. And just to kind of review, it is the preferred step 3 and step 4 therapy for patients 4 years and older. The maximum daily puffs of formoterol that they recommend from ages 4 to 11 years old is 8 puffs daily. And that includes the 2 puffs twice a day that they use for the controller medication. For patients 12 years and older, they recommend that you don't go over 12 puffs a day. And again, that will include the 2 puffs twice a day that they already use for control. So in these studies, when they compare the use of what we call SMART therapy, so single maintenance and reliever therapy versus using just a higher dose of an inhaled steroid, SMART therapy was associated with a significant reduction in asthma exacerbations, improved symptom scores, overall cumulatively reduced dose of inhaled and oral corticosteroids. And with that reduced dose of inhaled steroids and corticosteroids, there was a lower risk of growth depression in patients 4 to 11 years old. When you compare SMART therapy with a equivalent dose of a daily ICS LABA, but replacing the rescue ICS LABA with albuterol, the SMART therapy again won out with a significant reduction in exacerbations and similar or improves asthma control. And I think what is another big hangup of ICS formoterol reliever is just wondering what the safety of this is as a medication to use multiple times per day. So there has been some studies, mostly in adults, that at least there's no safety concerns with a dose of Symbicort, 10 puffs over 1 hour. And this is on top of maintenance treatment of 4 puffs of Symbicort. There are no safety concerns when just using formoterol by itself, up to 90 micrograms over 3 hours. And at least when looking at the study, there weren't any difference in harms between SMART therapy and the other groups, whether that's the higher inhaled steroids with albuterol or the similar equivalent dose of ICS LABA and using PRN albuterol. So the considerations for SMART therapy, when it comes to benefits, again, you have the decreased risk of growth suppression just because there is a lower exposure to corticosteroids overall. You have a decreased confusion of reliever versus controller medications, which we all run to with patients using albuterol two puffs twice a day, and then using their Flovent as needed. So you don't have that confusion with this plan. And for patients who are not as adherent to their medications, they will at least get some controller benefit if they only use it as needed for symptoms, as they are getting at least a little bit of that inhaled steroid with each time that they use their rescue inhaler. The concerns is that for particularly bad months, you're going to need to have more than one inhaler per month, and which leads to the question: will insurance cover it? As far as I'm aware, there sounds like there are some insurance plans that will cover for more than one Symbicort or Dulera inhaler per month, but it doesn't seem very common, or it doesn't seem like it's going to get to a point where it's universal anytime soon. And then even when you check Dulera or Symbicort's website, even today, they have this little thing at the bottom where they state that it's not to be used for sudden breathing problems and not to replace a rescue inhaler. So despite all these studies that have been done, even the manufacturers themselves are hesitant to endorse themselves as a rescue inhaler. So this is on Symbicort's website, and the same thing in Dulera's website. Nice and bold, not to be used for sudden breathing problems. So in summary, there has been a push to replace albuterol for rescue with ICS formoterol. This seems to be more the case in internationally. Here in the US is very limited, mainly by insurance approval and mainly by safety concerns, especially when we talk about what do we do with kids who are in a severe exacerbation and need more than their 4 to 8 puffs at once. And also another big thing for certain groups, and this includes your very young viral wheezers or your older adolescent patients with mild asthma, there is an option to use an inhaled steroid with albuterol just as needed versus taking an inhaled steroid every day. So these are my references, and I would be happy to take any questions you have about this presentation.
Thank you very much, Dr. Martin, for coming back. And this was very, very helpful. Do you feel like in a pediatric office, there is any benefit for the peak flow meter?
For peak flow meters, I tend to stay away from them. One, that they're very effort dependent, and two, you can have a very normal peak flow and still have significant lower airway obstruction. To me, a better indicator of a severe exacerbation of a patient having asthma symptoms is just looking at them. I think by the time you see a true significant reduction in peak flow, that patient most likely is already having obvious symptoms of asthma. There are exceptions. Again, you have your poor perceivers, these older patients with severe asthma. I remember one, at least during residency, whose asthma was so bad that basically he would tell the PICU when he needed to be intubated. And he was always just so significantly obstructed that we would actually have him do peak flows every day. And since he was pretty good at them, those are pretty reliable. In general, I really don't rely on peak flows, and I don't really trust patients and their families to really interpret peak flows or to do peak flows correctly.
So do you think we should refer patients to you, anybody that is not, anybody with persistent asthma as you, right?
I think it's up to you. I think for mild persistent asthmatics, I think there's definitely room for pediatric for primary pediatricians like yourself to put them on a low-dose inhaled steroid or a low-dose inhaled steroid LABA combination. I think that's fine. And then if they're still not being controlled with that initial controller therapy or up to an additional step up to an inhaled steroid long-acting beta agonist, I'd be happy to see them.
Thank you very much.
Of course. Any other questions, thoughts, concerns? I thought I was introducing a very controversial topic here, but it seems like everyone's pretty happy about the use of inhaled steroids of Flovent 223 puffs twice a day. At least I know the pharmacists are. I keep getting calls from them talking about I'm going to just completely crush these kids' bones to smithereens.
Hello. Sorry.
It's okay.
All right, well, perfect. Are any more questions? I just want to make sure I don't overlook anyone. I think we're good to go.
Yeah, thank you very, very much. This was extremely helpful. I really appreciate it. We all appreciate it.
Of course, of course. So we're so happy to continue to build this relationship with you all. We will see you back again April 25th with Dr. Martin again to go over outpatient radiation.
Perfect.
I believe-
We're looking
yes.
forward.
I love it. Well, I appreciate you all. You guys have an amazing, amazing Tuesday, and we will talk to you guys soon. Thank you, Dr. Martin.
Thank you guys. Thank you, everyone. Have a good day.